Okay, it's 12 and I've got a lot of slides, so I'm going to go ahead and get started. Welcome. For probably maybe the one person who doesn't know me, hi, I'm Brittany. I'm one of the clinical pharmacists on staff, and I round with internal medicine, and I also serve on the anticoagulation service at the pharmacy. And today I'm going to talk about updates in periprocedural management of anticoagulants. This is a topic that I was preparing for medicine rounds, and as I was combing through a lot of the information, I came across, of course, a lot of pearls that I think are really pertinent to pharmacy practice, but will probably also be relevant to your practice as well. So before I get started, of course, I have to let you know that although I wish I had, I don't have any financial disclosures. And the objectives for this presentation are primarily going to be limited to anticoagulants just for the sake of time and keeping things sort of organized and not confusing. I don't have time to cover antiplatelet agents, but I can try to address those questions if you have any at the end. So we're just going to go through and look at sort of the basics, starting with indications for bridging around surgical procedures. How do we do that? How do we determine patient and procedural risks? We'll talk about how to develop an evidence-based plan for bridging based on each agent's specific pharmacokinetic profile. And then we'll also look at post-procedural recommendations for when should we be resuming these agents after completion of the procedure. So this is a pretty timely topic. The reason it's important to talk about it is because we all well know that interruption of anticoagulants is very common. So on an annual basis, we're talking up to 15% almost of patients with either mechanical heart valves or atrial fibrillation. And there are varying risks that depend on the patient and also their history and comorbidities. So it's not very well defined, and there are multiple sources, multiple guidelines and consensus recommendations that make management of anticoagulants around the time of surgery pretty complex. And this complexity, of course, has increased with the changing landscape of oral anticoagulants. So we now have 4 direct oral anticoagulants that we can see used for these primary indications of AFib or VTE. And when deciding on your periprocedural management, you have to have an in-depth knowledge of how to sort of decipher and calculate patient bleeding risks, but also how to understand the thrombotic risks that are associated with their particular history or even the surgical procedure, and blend all of that information to make a very patient-specific plan for their anticoagulation. So it's not black and white, and it's not one size fits all. And then to further complicate things, I tend to sort of have blinders on and think of everything from an inpatient perspective, but I'm sure, as Lacey can probably tell you, that these complications and these questions aren't limited to what we do in the inpatient setting for emergent or elective procedures. And so evidence shows us that there's huge potential for gaps in care for patients who are on anticoagulants, as different providers, their proceduralists, their primary care physician, their cardiologist, maybe a nurse practitioner, or even a pharmacist in an anticoagulation clinic are all trying to develop an anticoagulation plan, communicate that to each different provider, to the patient, execute that plan, and make sure that we're all on the same page, and that can be difficult to do. So although we are not a Joint Commission accredited institution at this time, many other facilities across the nation are. And so this report by the Joint Commission with updated national patient safety goals for this year, I think really highlights the fact that there's a lot of uncertainty about how to manage this problem. So one of these goals says that institutions should have approved protocols and evidence-based guidelines in place for anticoagulation reversal. Okay, so Erlanger has that. We do have a document that's available on the intranet that guides reversal of various anticoagulants and antiplatelet agents. And you know, I worked really closely with Bree, and we agreed with our surgery department on how we're going to approach this as an institution in terms of reversing agents. Another goal that the Joint Commission has set forward that we don't currently have in place is using approved protocols for perioperative management of all patients on oral anticoagulants. So any Joint Commission accredited organization across the country right now is having to struggle with developing these types of protocols. Something else that lends to a lot of uncertainty around bridging is the fact that many different specialties have their own recommendations for periprocedural bridging. So depending on the specialist you're talking to or who's planning the surgery or who's managing their anticoagulation, you may have different thoughts about what's appropriate for the patient. So in the last 5 years alone, this is just showing you how many different specialties have released guidelines on perioperative management of anticoagulants. And also during that time, we've had a publication of 2 very large observational prospective studies and 2 randomized controlled trials that are sort of feeding into our considerations for these guideline recommendations. So as we move through how to decide to manage anticoagulation around the time of surgery, there are basically 4 key questions that you have to consider. And this is kind of how I've organized the rest of the presentation. So we'll go through these one by one and look at the evidence for each. The first would be, should the anticoagulant be stopped at all for the procedure? This requires a pretty in-depth and detailed evaluation of what is the bleeding risk associated with the procedure, and then also what is the patient's bleeding risk. And so we have to weigh both of these things and you know, really take a close look at what are the risks and benefits in both situations to make sure that for this patient and for this procedure that we've considered everything before we just sort of rip off the Band-Aid and stop the anticoagulant because we're fearful of any bleeding. There is no validated tool to evaluate procedural bleeding risk. So that's one thing that makes it very difficult to determine whether or not it's safe to continue or to hold an anticoagulant. So what you're looking at here is, you know, we have well-defined high and low risk categories. So this is not all-inclusive, but what I've done in here is include procedures that are common and that have well-described bleeding risks in the literature. So as you might expect, things that carry a high bleeding risk, so that would be more than a 4% risk of major bleeding within 48 hours of the procedure, would be any major cardiac surgery, PEG placement, maybe a colonoscopy with removal of polyps, liver biopsy, orthopedic surgeries, and also, obviously, any neuraxial procedure is going to be very high risk for bleeding. And so these are situations that would warrant holding the anticoagulant or, if necessary, in emergent or urgent situations, potentially reversal of that agent. And when we're talking acceptable reversal with warfarin, that tends to be an INR of less than 1.6. And that's primarily defined by interventional radiology guidelines, but that's one of the only sources that I found that really comments on what is the acceptable INR for the procedure. Low-risk procedures would be those that carry a very minimal to negligible risk of bleeding shortly after the surgery. We even have evidence now that some of these procedures not only do you not have to reverse the agent, but it's safe to continue anticoagulation through those. And so those would be things like ablation of atrial fibrillation or implantation of cardiac devices. So we saw that in the bruise control trial, that patients who continued their warfarin actually were less likely to develop hematomas after surgery than patients who had their warfarin held and were then bridged. Abdominal paracentesis, endoscopy procedures without resection are considered low risk of bleeding. And then we know there are certain procedures where you don't have to stop the Coumadin or the DOAC at all, and those would be things like simple dental extractions, minor skin procedures like skin biopsies, and cataract surgery. So for low-risk procedures, you either don't hold the warfarin at all, or depending on the patient's bleeding risk, you would consider a lower level of anticoagulation. So that could be anywhere from an INR of 1.6 to 2.5 if you're talking about Coumadin. For patients on DOACs, you can consider holding the dose the day before the procedure instead of holding for a longer period of time. That would ensure a complete washout of the drug. So that's how we're going to weigh procedural bleeding risk factors. I think it should be noted that, there's no one way to completely grasp what is the true bleeding risk of any surgical procedure. This is primarily based on case series data, and so it's really important that they have a conversation with the proceduralist because a lot of these bleeding risks come from experience of the proceduralist as well. For patient bleeding risk factors, this is primarily done by the Has-Bled score. So the Has-Bled score was a bleeding risk score that was validated in patients with atrial fibrillation, but it also has been shown to be predictive in the surgical setting. So a Has-Bled score of 3 or more would indicate that your patient has significant risk for bleeding, and this would include the factors listed there below. Other risk factors that would carry significant weight with one of these alone for bleeding would be, of course, a patient who's had recent bleeding, so in the last 3 months, or have they bled before during another surgical procedure. Patients who are on concurrent antiplatelet medications and also those with thrombocytopenia would be considered at increased risk of bleeding. So let's say we've decided to stop the anticoagulant based on the procedural bleeding risk and the patient's bleeding risk. When should the anticoagulant be stopped? With warfarin, this is a really well-described process. Everybody's very familiar with the recommendation to hold warfarin for 5 days before procedures that carry a significant risk of bleeding. This is more complex, though, with the direct oral anticoagulants. So with the DOACs, we don't really have any one reliable assay to determine how much of the medication is still in the patient's system that would give us confidence before we take them to a procedure. And I'll talk about some various coagulation assays we can look at, but we don't really have any way of measuring a very specific drug level. You also have to consider the individual agent pharmacokinetics. So it's not a one-size-fits-all type of approach with DOACs because they all have varying degrees of renal elimination, and we see that there are different recommendations depending on the degree of renal insufficiency for how long we have to hold these agents. And the important thing to remember when considering how long to hold a DOAC before a procedure is that the patient's creatinine clearance is one of the biggest factors in consideration. So we can't use the GFR for an estimation. Studies that indicated or that looked at appropriate holding times before procedures used patients' total body weight and the Cockcroft-Gault formula to calculate a creatinine clearance to determine how long to hold that agent before a procedure. So we'll look at that a little more closely. So in looking at the oral anticoagulants, of course, warfarin has the very long half-life. This is related to its inhibition of producing the clotting factors 7, 9, 10, and 2. Periprocedural management of warfarin is well described. It's in the CHEST guidelines. We saw from the BRIDGE trial looking at management periprocedurally with AFib patients that it's a pretty reliable process, holding the warfarin at least 5 days before a procedure. We should also consider, though, that that's not true for everyone. So patients who are elderly, who have significant organ dysfunction, anyone who would be expected to have reduced hepatic metabolism, it may need a little bit more than 5 days to clear Coumadin before they can have expected low levels of medication in the system before taking them to surgery. And so it's recommended to actually check an INR at least 24 hours before the procedure to make sure that patient is expected to achieve their INR goal before you take them to surgery. In the case of urgent procedures or emergent procedures, this is when it becomes acceptable to reverse warfarin. So this would be a lot of our hospitalized patients. We do this with vitamin K either intravenously or orally. So we get a question a lot on the clinical side about whether or not subcutaneous administration of vitamin K is ever appropriate or ever permitted. And the answer to that question is yes, it's available. It's an appropriate route of administration, but probably not for reversing warfarin if you want to ensure that your patient has low levels of anticoagulation in their system before the procedure. So for that reason, because subcutaneous vitamin K is very erratically absorbed, you should strongly consider recommending oral or intravenous vitamin K for reversal of the warfarin. The dose that you give is variable. For urgent and emergent procedures, there's no hard and fast recommendation as to what is the best dose of vitamin K in those situations. So 5 to 10 milligrams is what's recommended in the guidelines. I think that would probably depend on how high your INR elevation is and how soon you need to take that patient to surgery. You can also consider fresh frozen plasma, and for life-threatening bleeding, of course, this is when Kcentra comes into play. So for a patient who's bleeding and has only minimal elevations in the INR, let's say their INR is less than 1.5, and they've been on warfarin, Kcentra would probably not be appropriate for that patient because you've already have your INR reversed, so to speak, to an acceptable range. So supportive measures would be appropriate in that situation. However, for patients who have therapeutic INRs or elevated INRs on warfarin who need to go to surgery or have life-threatening bleeding, Kcentra would be appropriate. The dose is based on the INR. I have not listed that here because we have an order set where you can find that information. But one of the most important things you can do in that situation is also load that patient up with vitamin K. Kcentra has a half-life that is going to be shorter than the warfarin itself, and so if you fail to administer vitamin K with the Kcentra, you can have a rebound elevation in the INR and put your patient at risk for subsequent bleeding. With the DOACs, these are pretty predictable, a lot more predictable than warfarin in their pharmacokinetics. They all have a very rapid onset, so that's something to think about when we're resuming these after a procedure, right? We're often comfortable resuming warfarin fairly soon after a procedure because we know it takes quite some time to come into effect. But with the DOACs, you have activity as soon as, say, Lovenox, so within a couple of hours. And the half-life of these agents is around 12 hours on average. Rivaroxaban has a little bit shorter half-life. But where they primarily differ is going to be their renal elimination. So dabigatran isn't used very often, but when you see it, you need to remember that it has significantly more renal elimination than any of the anti-10A inhibitors. Rivaroxaban, apixaban, and edoxaban are on average about 30 to 50% renally eliminated. So that comes into play when we're deciding when to hold them before the procedure. So this is a table that I've adapted from the American College of Cardiology guidelines. Before 2017, when this was published, anytime you called pharmacy to get a recommendation for when to hold a DOAC, we were doing our best to calculate pharmacokinetics based on the half-life of the drug and what type of procedure they were about to undergo. In 2017, though, this was the first consensus recommendation for a defined preoperative approach for DOACs. So what you'll see here is for anyone with a low bleeding risk, for either apixaban, edoxaban, or rivaroxaban, if the procedural risk is low, holding for 24 hours at a minimum is appropriate, and you can feel confident that you have minimal amounts of the anticoagulant in the system after that time. For creatinine clearance 15 to 29, at least 36 hours has been defined as the appropriate amount of time to hold. And for those with further reduced renal function or on dialysis, you need to consider holding for a significantly longer period of time. This data says at least 48 hours, but I think generally across the board we'll recommend at least 72 hours before you take the patient to the procedure. These guidelines do recommend considering an anti-10A level. It should be remembered we don't have assays that are calibrated for that in our lab, and so you can't use it as a definitive and quantifiable amount of how much drug is in the body, but seeing an elevated anti-10A level could let you know that there's a significant amount of drug in the patient's system. For high bleeding risk procedures, or if you're not sure, just remember we want to hold those a little bit longer. So anybody who's going for a cardiac procedure or biopsy, maybe they've been on Eliquis, for example, or apixaban, even if they have normal renal function, it's recommended to hold that for at least 48 hours. And when you have creatinine clearance under 30, we just don't really have a lot of data for high-risk bleeding procedures. So that would be where you'd certainly hold for at least 3 days before comfortably sending that patient to surgery. Dabigatran is a little different. Remember, it was 80% renally eliminated, and it has a much more stratified recommendation for when to hold and how long to hold based on the creatinine clearance. So for low-risk procedures, again, you see kind of like the 10A inhibitors, if the renal function is pristine, you can hold for about 24 hours and feel comfortable. With high-risk procedures or intermediate, or you don't know the procedural bleeding risk, you want to wait at least 2 days. And then you can see here, as the renal function decreases, we add on additional time to allow that drug to clear from the system, and we have no data for dialysis patients. So that's kind of just a swim at your own risk situation. So we often get asked, my patient's been on rivaroxaban, I want to take them to the procedure. I think it's been more than 12 hours since their last dose, but is there any test that I can order to show me how much medication is left in the patient's system? And the quick answer to this is not really, but this table in the highlighted dark areas is showing you different coagulation assays that you might see elevated for patients on these medications. So for dabigatran, the direct thrombin inhibitor, it can have some minimal effect on the INR, but you're more likely to see elevations in the APTT and thrombin time for patients who still have significant amounts of drug left in the body. For the 10A inhibitors, though, they're much more likely to prolong the INR, and that's especially true with rivaroxaban. I've seen INRs as high as 4 to 6 in patients on rivaroxaban, and what's important to remember is that your INR is not linearly correlated with the degree of anticoagulation. So all this can tell you is that there are probably significant amounts of anticoagulant in the patient's system, and you either need more time, delay that procedure, or perhaps you would be prepared in the OR, have supportive measures on hand, expect maybe some bleeding, and keep an eye out for that. But the biggest thing I can emphasize here is that normalization of these coagulation assays does not preclude it having any anticoagulant in the system. So you can't trust that because the INR is normal, that patient's safe to take to surgery who just took their rivaroxaban 8 hours ago. So if we do want to reverse the DOAC, when and how should we do this? So I pulled these recommendations from the Journal of Thrombosis and Hemostasis and the American Journal of Hematology. These are situations where we could recommend or consider using a reversal agent for a direct oral anticoagulant. So if the procedural risk of bleeding is high and we cannot safely perform that procedure on anticoagulation, we can consider. If the procedure is emergent and we cannot delay that procedure, we can consider reversal of a DOAC. Or if there is a reasonable expectation for clinically relevant DOAC levels and that procedure carries a high risk of bleeding, we can consider reversing. They also point out we should specifically avoid reversing in these situations. So any elective procedure, so we want to just allow time to do its job, not reverse these agents, right, because reversal agents carry a risk of thrombosis. And GI bleeds that are going to stop with supportive measures. So this means trying to perhaps fluid resuscitate a patient with a GI bleed, see if they're responsive to that, to blood products, and if supportive measures aren't effective, then you could consider reversal of the DOAC agent at that time. And then if the patient has excessive anticoagulation without any active bleeding, and that's also sort of an uncomfortable area for a lot of providers. You don't often encounter DOAC overdoses, but in the case that you do, there is not a recommendation to provide an empiric reversal agent for that patient in the absence of bleeding. So this is just kind of summarizing general recommendations for reversal. In the unlikely event you have a patient on Pradaxa who does have life-threatening bleeding and needs reversal, we have idarucizumab. So this is a monoclonal antibody that's given in 2 separate doses, 2.5 grams each to total 5 grams. You can also remember that dabigatran is dialysable, whereas the 10A inhibitors are not. For apixaban, edoxaban, and rivaroxaban, the currently recommended reversal agent is Kcentra, and this is becoming controversial. We know with Kcentra, we've seen studies using Kcentra to reverse DOACs that show adequate hemostasis, and these have become kind of the standard of care for reversing DOACs. What's questionable now is what is the optimal dose. So this carries a certain price tag. Kcentra also carries an increased risk of thrombosis. And so for that reason, some guidelines and facilities are kind of steering away from the fixed weight-based dose of 50 units per kilo. And instead, we see that a dose of 2,000 units, regardless of weight, is also shown to be to result in effective hemostasis. So this is something we're currently looking at doing, not only from a cost perspective, but also a safety perspective. It should also be remembered that with Kcentra, even if the INR is elevated, we should never use the INR to determine the dose of Kcentra. And this was something that we found was common practice when we did an evaluation last year. Indexanet has also made its way into guideline recommendations for reversal. This is a huge question that we get from providers. We have no plans to bring this on formulary right now, and I'll tell you a little bit more about that on the next slide. And it should be remembered that dialysis will not effectively remove any anti-10A inhibitor because of their large molecular size. So Indexanet alpha is FDA approved. It was fast-tracked based on a single-arm study that showed that it was effective at achieving hemostasis in patients who had life-threatening bleeding on, for example, Eliquis and Xarelto, but it's not on our formulary. One of the reasons for this is that we have information that tells us Kcentra is appropriate and that it works, and we don't have any comparative outcomes data with Kcentra at this time. Bree brought to my attention recently that there is an abstract that's currently published. We're awaiting journal publication, but it was a study of trauma patients who were known to have recently taken a direct oral anticoagulant, and they compared those who had reversal with Kcentra to those who had reversal with Indexanet. And the preliminary data shows that the mortality rate looked significantly increased in the patients who had reversal with Indexanet. So we'll kind of await the details on that. Indexa also has an increased risk of thrombosis that earned it a black box warning. It's difficult to compound, so when you call for this agent, it's not going to be 15 to 30 minutes till you get it, like with Kcentra. It could be as much as an hour. We also have evidence that after or during the infusion of Indexanet, if that patient needs to go to a procedure where you expect that you may need to use intraprocedural heparin products, those are not going to work while the patient is receiving or has recently received Indexanet, and so that can put the patient at increased risk of thrombosis. And then the price tag, just to top all of that off, you're talking about potentially $50,000 to reverse the drug for your patients when we have no information that it's any better than Kcentra. So at this time, formulary status is pending. All right, so the next question that we have to consider is, does the patient require bridging? So bridging was a concept that came about in patients who were on warfarin who would have their medication held prior to a surgery. And the question is, what should we do with this patient in the meantime to prevent a thrombotic event in the time leading up to the surgery? So this is usually done with a parenteral anticoagulant, usually in therapeutic doses. And it allows you to continue a short-acting anticoagulant during the discontinuation of your warfarin for elective procedure or surgery. It should be pointed out that bridging is never indicated for patients who are receiving DOACs. The only time you would consider using a parenteral anticoagulant in a patient who is on therapy with a DOAC should be patients that, for example, come out of surgery and have prolonged NPO status and we can't safely administer an oral medication. So those patients, if they have a high risk of thrombosis after the procedure, but they can't take their DOAC, we wouldn't call that bridging, but you would provide them with a parenteral anticoagulant in the meantime until you can resume their DOAC. And also remember that bridging with DOACs, and I don't know why you would want to go from a DOAC to warfarin. It would just seem you wouldn't stick with the DOAC. But we do have scenarios that come about where patients are going to be taking warfarin long term, and perhaps maybe they won't comply with Lovenox injections for bridging. So we get questions about, can I bridge this patient with rivaroxaban while their warfarin is becoming therapeutic? And so there are actually guidelines on how to do that. We don't recommend that here, but you should remember that these DOACs, for example, Xarelto, can significantly elevate the INR. So that can lead to confusion when you're trying to determine when it's safe to take away the DOAC and continue the warfarin, because you can't be sure if that INR elevation is partially attributable to the DOAC or is it only due to the warfarin. So that's a disadvantage of bridging with a DOAC. And the reason I want to talk specifically about whether or not even to use bridging at all, because this is a very touchy subject depending on what specialty you work for, but there is mounting evidence over the past 5 to 10 years that even in high-risk patients, bridging with parenteral agents, the bleeding risk far outweighs the rate of thromboembolic events in the temporary interruption of an oral anticoagulant. So I'll show you some of that data. Before I can show you the recommendations, though, you have to sort of wrap your mind around how we define high, moderate, and low risk for a thromboembolic event. So for patients with mechanical heart valves, contrary to popular belief, these aren't all high risk for thromboembolic events. Patients who are at high risk of having an event with a mechanical valve would be those with a mechanical valve in the mitral position, an older valve, and we don't see this often, but caged ball or tilting disc aortic valves, or those patients who have a mechanical valve and had an arterial thromboembolic event in the past 6 months. Moderate risk mechanical valves would be an aortic mechanical valve with another risk factor for stroke, and I've listed here the risk factors, but they're those that are in the CHADS-VASc score. And mechanical valves that are in the aortic position with no other risk factors for thromboembolism are actually considered low risk. Patients who have AFib, so we have a lot of information and well-done studies, high-quality studies that confirm this. This is kind of surprising to me, but we don't consider patients high risk with AFib until their CHADS-VASc score is 7. Anyone who's had an arterial event or a stroke, TIA, within the last 3 months is high risk, and patients with rheumatic valvular disease. Moderate risk would be patients who have a CHADS-VASc of 5 to 6. So I'm only focusing on CHADS-VASc here because that score is preferred to CHADS at this time. And low risk is 1 to 4. And then in patients who have had a VTE, high risk would be, it's basically related to time since last event. So you're at highest risk if you've had a clot within the last 3 months, or if you have a severe thrombophilia, and those are protein CNS deficiency, antithrombin deficiency, antiphospholipid antibodies, or maybe you have multiple thrombophilias. Moderate risk would be 3 to 12 months since your last VTE, or having a non-severe thrombophilia. Or you've had a clot, but it's been more than 12 months and you don't have any other risk factors for a clot. Okay, so those are how we're going to, when we go through these recommendations, how we define high, moderate, and low risk. So to bridge or not to bridge, and I'll divide this up by category. For patients with a VTE or history VTE, CHEST and American Society of Hematology guidelines agree for high risk. These patients should be bridged during the time they can't take their warfarin. There's a little difference in opinion for low to moderate risk. For low risk, both CHEST and ASH guidelines say don't bridge. For moderate risk, CHEST kind of raises up their hands and says, you need to consider a risk-benefit evaluation. We're not really comfortable telling you how to decide in a moderate risk VTE patient. Patients with AFib, again, this is very well defined based on results of the BRIDGE trial that came out several years ago. Low risk, so those who don't need any bridging are going to be patients with a CHADS-VASc of 1 to 4, and they have not had a prior stroke or TIA. Don't bridge those patients. Moderate risk would be CHADS-VASc 5 to 6, or if they've had a prior event, it's been more than 3 months since they've had that stroke or TIA. Situations where you would not bridge a moderate risk patient is they have a significantly increased bleeding risk. And they say likely do not bridge if they have a moderate risk, but they've never had a prior stroke or TIA. and then we would likely bridge a moderate risk patient who has had an arterial event in the past. High-risk patients, we always bridge. Even in the patient who has increased bleeding risk factors, these guidelines say you should strongly consider a bridge. So how do we do that? What's the optimal dose of heparin? This is a big point of uncertainty. The reason that therapeutic dosing is recommended is primarily because that's what we've seen in observational studies, that's what providers are comfortable with, but there's actually no information that compares different regimens of heparin products and says this regimen is more likely to prevent thrombotic outcomes than this one. So the CHEST guidelines, they recommend therapeutic doses of a heparin product, but they do acknowledge that they're not really sure about the benefit of that because they acknowledge the increased risk of bleeding. So heparin infusions can be used. We see this done a lot in patients who are surgical patients, may have to go back to the OR, or we're just kind of scared that they might bleed. But I think it should be mentioned, and it's important to know that time and therapeutic range for heparin at this institution is quite low, so less than 40%. So you're not guaranteed that your patient actually has a therapeutic amount on board, and we don't know whether that means they're super therapeutic or they're just not protected at all. So for that reason, we strongly recommend use of the more predictable agent, enoxaparin, for patients that don't have contraindications to this agent that has a longer duration of action. It is still partially reversible, and we recommend 1 mg per kg BID for therapeutic dosing. The once daily strategy carries a higher risk of bleeding and is not preferred, but may be an option for patients who are averse to doing an injection twice daily. CHEST guidelines also acknowledge that there are intermediate dose and low dose, but they don't really say when to use these strategies. So something that comes across to the pharmacy often is questions about how should I bridge, or we'll verify an order for a low Venox regimen that isn't quite 1 mg per kg, and it's not really anything else either. It doesn't really fit into any guideline. And so my point here that I want to make is we don't know what's most appropriate. We don't know that Lovenox 40 milligrams Q12 hours is any less likely to prevent a thrombotic event than 1 mg per kg twice a day. But we do know that therapeutic dosing can increase the risk of bleeding by up to 4 times that of non-bridged patients. So that's really something to consider. So what do we know in patients with AFib about bridging? Based on studies from Siegel and colleagues and Steinberg with the ORBIT-AF trial, and of course with the BRIDGE trial, that was our only randomized controlled trial looking at bridging in AFib patients, these all communicate the message that the risk of bleeding in these patients is very high and that the thromboembolic rates are low. So the message for AFib patients now is that we should not be bridging them unless they have high risk of an arterial event. The question, though, so there's no question about whether or not we should bridge, really, unless they're high risk. But the question is, what's the best plan for AFib patients on DOACs? So Deketis and his co-investigators published this study called the PAUSE study last year. And what they wanted to do was establish a one-size-fits-all holding strategy for patients who were on any direct oral anticoagulant. They also wanted to know what DOAC levels looked like before surgery, just to sort of see, you know, what really is the quantifiable amount of the anticoagulant in the system in a broad range of patients who are about to go to surgery. So they included patients in this study if they had a creatinine clearance over 30. The average CHA2DS2-VASc score was about 3.5, which is really similar to the BRIDGE trial. You can see on this table that a significant number of these patients were presumably had renal dysfunction, so they were on a low-dose DOAC, and about 12 to 15% of these were also receiving aspirin. And we're looking at about over 3,000 patients on apixaban, dabigatran, and rivaroxaban. Their procedure was this. If you were undergoing a low-risk procedure, they held your DOAC for 1 day. So this is anybody with a creatinine clearance over 30, which is a little contradictory to the American College of Cardiology guidelines. If you were undergoing a high-risk bleeding procedure, they stopped your DOAC 2 days before the surgery. And if you were on dabigatran, because it's more renally eliminated, it was at the discretion of the provider whether they wanted to hold for an extra day or so. After the procedure, they resumed these agents as defined in the CHEST guidelines, so nothing new there. And what they found was that thromboembolic event rates were low across the different DOAC groups. And they also saw that they had a less than 2% rate of bleeding, whether the surgery was major or minor, and that was what was predefined goal before they started the investigation. And what I find interesting is that in a significantly high number of patients, so about 95% of patients, the residual anticoagulant effect by holding it with this protocol resulted in most patients having acceptably low levels of anticoagulant. So less than 50 was the cutoff. Anywhere from 30 to 50 in the literature is acceptable. So even patients who had moderately reduced renal function did show negligible residual anticoagulant effects before the procedure. So the authors concluded that this should be applied as a standardized DOAC management procedure because of the low rates of bleeding that are similar with previous studies and a low rate of thromboembolism that we've seen previously in the literature. They also confirmed that we don't need to be checking coagulation assays for patients who are on DOACs before a procedure, and also stated we should not be bridging patients who are receiving DOACs. So in AFib patients, before we move on, we should not be considering bridging in patients who have low to moderate thromboembolic risk based on the CHADS-VAS score or history of stroke. We now have a standard perioperative protocol based on the pause results that we can use and feel comfortable with. The questions that we now have are when we do bridge, what dose of heparin should we be using? That's not well defined. And what is the ideal strategy for holding DOACs in patients who have a creatinine clearance less than 30? We still don't know. And now this is kind of what I consider the juicy part, and we're rounding out to the end here, but bridging in patients who are considered high risk, mechanical heart valves and venous thromboembolism. The problem with this is even in all the data that I combed through, there are no randomized controlled trials that give us confidence about how to bridge or whether to bridge in these patients. A lot of guidelines talk about pre-procedural bridging strategies. No one comments on whether to bridge post-operatively, so there's a lot of uncertainty here. Most of the studies that are available are very low-quality observational studies. But of all the studies that I combed through, and there were many, the majority of those in the past several years are challenging the practice of bridging patients with mechanical heart valves and a history of VTE because just like with AFib, we see that the thromboembolic event rate is very low. So anytime we define risk for thromboembolic events, this is based on annual risk. No one's ever elucidated what is the risk of a clot in a temporary time period when we're holding anticoagulants. But we do see that the rate of major bleeding far exceeds the rates of clots. This is talking about VTE patients only. This is the first large systematic review that was conducted looking at literally every published comparison of bridging versus non-bridging available in PubMed since PubMed's inception. And they, of course, whittled that down to certain parameters because you can imagine that would be, impossible. And what they finally got down to was 28 non-randomized studies. So there are no randomized studies. But they looked at all of these, looking at patients who were bridged versus those who were not. 19 of these were prospective, so that's better. And all of the patients were on warfarin, no DOACs, just warfarin for secondary VTE prophylaxis. Some of these patients had mechanical heart valves. Some of them have AFib. They included both major and non-major major and non-major surgeries, and most of these studies followed patients for as many as 90 to 180 days after surgery. It's important to remember, though, that as I present these results to you, that bridging strategies were based on the provider's discretion. In the bridged groups, the majority of these studies did anticoagulate the patient both before and after the surgery with heparin, but that heparin dosing strategy was not congruent among any of the studies. So what Baumgartner and her colleagues showed was that if you look here, the pooled incidence across all of these studies of VTE in all of these high-risk patients was very low and very similar to what we've seen in atrial fibrillation patients. So 0.7 in the bridged group, 0.5 in non-bridged groups across all studies. And this was similar as you go through the subgroups. And as they evaluated patients or studies that included less than 100 patients, and compared those with larger studies, they found that these results of low event rates were stable. In the major bleeding evaluations, they found, though, when you compared bridged and non-bridged groups, the risk of bleeding far outweighed the risk of thromboembolism, and the risk of bleeding was significantly greater in any bridged group. And then all bleeding, of course, so this is any bleeding clinically relevant, non-relevant. We see that those elevated bleeding risks still hold true. So the conclusions that these authors made, although they acknowledged the poor quality of this study, was that even in high-risk patients, we see an increased risk of bleeding that does not correlate with reduced thrombotic events. So they suggested that periprocedural heparin products, bridging, is overused in patients who are at low or moderate risk of a thromboembolism, but they did acknowledge, we need to pursue this further with more high-quality studies. In patients with mechanical heart valves, we have various groups that define when we should consider bridging in these groups. And so it's not all of them, which is kind of surprising. I think practice is very variable among different specialties here. Low-risk valves, so that would be an aortic mechanical valve. Patients not had a stroke before. They don't have other risk factors for thrombosis. The CHEST guidelines and the American College of Cardiology say go ahead and interrupt the warfarin and don't bother bridging. In high-risk valves, the American College of Cardiology has dropped their level of recommendation for bridging to saying that it is reasonable to bridge a patient with a mechanical heart valve, a high-risk valve. So they don't, across the board, say, yes, we should bridge these patients anymore. They're kind of leaving it up to the provider, encouraging you to consider their bleeding risk factors. So that's changed. The CHEST guidelines, though, for high-risk valves, they do suggest bridging versus no bridging, but they don't really comment on what is the optimal dose of heparin. They do delineate that there are different appropriate strategies for heparin bridging, so it's not always the 1 mg per kg. So that usually depends on if maybe the procedure has a high bleeding risk and your patient maybe also has a high Has blood score, for example. Those would be times when you might consider not using full therapeutic dosing with a heparin infusion or Lovenox 1 mg per kg. And then the European Society of Cardiology disagrees with the above recommendations and says for anyone with a mechanical heart valve, we think they should all be bridged. So some disagreement here, but the general message is we see that there's a lot of bleeding that occurs with bridging, and it may not be as protective as we think. So the last thing I want to bring to your attention is a study that's published in abstract form. It was released during the ASH meeting in 2018. I think the results of this trial could potentially change our practice. It was called the Periop-2 trial, and is a multi-center, randomized, placebo-controlled trial that looked at patients with AFib, or they had a mechanical heart valve that needed to have their warfarin stopped for a surgery. And so the question here that they wanted to answer is there any difference in efficacy? Do we really decrease the risk of thrombotic events? And are there differences in bleeding between bridged and non-bridged patients who are high risk for thrombosis or have previously been considered high risk? They looked at major thrombotic events or bleeding events at 90 days, and then, of course, looked at secondary outcomes of major bleeding or overall survival. Because I'm talking to you about high-risk patients, I don't want to confuse, what were they considering high-risk patients. It's important to remember, as we interpret the results, that they did not include patients with multiple mechanical valves. They did not include patients who had a mechanical valve and a previous stroke or TIA. Higher risk valves, the Starr-Edwards valves, were not included. And then major surgeries like cardiac and neurosurgeries were excluded, as well as patients who had renal failure. So the way they did this, they didn't use dalteparin, they didn't use enoxaparin, they did use dalteparin. The cool thing about this study is that they had 2 arms for bridging doses. So they used a dalteparin prophylactic regimen for low-risk procedures, and that would be the opposite. For low-risk procedures, you got a weight-based therapeutic dose. For high-risk procedures, they used more of a prophylactic dose of dalteparin. And then before the procedure, so these are only warfarin patients, but they held their warfarin according to chest recommendations. Before the procedure, you had your dalteparin dose reduced by half. That's pretty standard. We usually suggest holding for 24 hours before, but that was part of this protocol. And then after the surgery, of course, they resumed the anticoagulants in line with guideline recommendations. So interesting things here is that looking at high-risk patients, different heparin regimens. So when we look at the occurrence of major thromboembolism, we didn't see a big difference between groups. And so that's not unexpected based on the theme of this presentation. And when we look at major bleeding, we didn't see a big difference between the major bleeding groups either. So the authors suggested that we don't see any benefit from periprocedural bleeding in patients who have atrial fibrillation or a single mechanical valve, so either an aortic valve or a mitral valve, as long as that patient didn't have a previous stroke or TIA. But they do acknowledge that, we really need to define what is the real short-term risk of thrombosis, because I think that's the thing that's going to make us feel comfortable not bridging these patients. Here is when should we resume anticoagulants after a procedure. The caveat here is that there is no one safe time to resume an anticoagulant after a procedure. We want to make sure that patient is hemodynamically stable, they don't require further surgeries, that the proceduralist is comfortable with resuming anticoagulation. But in general, for heparin products, for low-risk procedures, you can pick those back up within 24 hours. For high-risk procedures, within 48 to 72 hours. It would not be recommended to bolus. For warfarin, we typically resume this within 24 hours of any procedure because it takes a lot longer to have its onset of effect. And with DOACs, you should resume based on the procedural bleeding risk. So if your procedure carries a high risk of bleeding, it might be prudent to wait 72 hours before resuming this because you want to treat its pharmacokinetics kind of like a heparin product. So in conclusion, periprocedural anticoagulation management is very complex, and there isn't a lot of certainty around most of the recommendations I've given you, but we do have guideline recommendations to tell us how to handle these patients. We do see now that bridging is probably more risky than we previously thought in any low to moderate risk patient. What we do need are standardized hospital protocols and even ambulatory practice protocols. So I would, like to see us work on creating a periprocedural management protocol here for our institution, and then just to reinforce the importance of not only thinking about how this impacts patients on the inpatient side, but communication with their outpatient providers for elective procedures as well. All right. So I am asked to provide quick case presentations, so I'll promise these will be kind of painless. BC is a 52-year-old male, 76 kilos, needs an abdominal paracentesis. The physician calls the pharmacist for a recommendation on warfarin reversal and a Lovenox regimen for bridging after the paracentesis. This patient's warfarin doses and INRs have been chronically stable, has a past medical history of AFib with a CHADS-VASc of 4. The rest is listed there. You can see his medications. His INR is 2.1 today. He wants to take the patient for the paracentesis within the next 12 to 24 hours. Hemoglobin and hematocrit are stable, platelets are within normal limits, and renal function is within normal limits. So the question first is, what is the procedural bleeding risk associated with an abdominal paracentesis? The answer to that is low. So what would be the best recommendation based on the presented evidence for reversal? And that would be that it is not indicated. What factors should be assessed to determine the patient's bleeding risk? Choose a HAS blood score, a history of the patient having bled in the past 3 months. I have no idea, A and B. This would be A and B. What is the most appropriate bridging recommendation after the procedure while BC is waiting for a therapeutic INR? Lovenox 76 milligrams, so that was his weight, right? 1 mg per kg Q12, 40 milligrams sub-Q Q12. We should not do this based on his CHADS VAS score or page the anticoagulation service for help. Oop, yes, you're right. I heard whispers of C. The answer is we would not bridge this patient. They had a CHADS VAS score of 4 and no previous history of stroke. And then finally, we have a 72-year-old female who has AFib and dysphagia, and she's scheduled to undergo PEG tube placement. You're asked to provide a recommendation for holding rivaroxaban around the time of the procedure. Her creatinine clearance is 45, and she has no major bleeding risk factors. So how long should we hold rivaroxaban beforehand? So is it a high risk or low risk? Don't answer this, Bree. Is it a high risk or low risk procedure based on available evidence? So this is considered a high risk procedure. So rivaroxaban holding a DOAC depends on the patient's creatinine clearance and also the procedural bleeding risk. So considering those two factors, we would want to hold for 48 hours before she can go to the procedure. That's it, and if you have any questions, I'll take those.